Welcome back, and we're going to pick up right where we left off on page 1202 on the neonatal assessment and resuscitation. You always want to follow standard precautions and always put on gloves before handling a newborn. A newborn will usually begin breathing spontaneously within 15 to 30 seconds after birth, and the heart rate will be 120 beats per minute or higher. So how would you count a newborn heart rate? Simply what you'll do is you'll take your stethoscope and place it over the baby's heart. Then you will count the heartbeat in 6 seconds. That's because the baby's heart is going to be beating so fast. Then whatever number you get in 6 seconds, all you do is you add a 0 to the end of it. For example, if you count up to 16 heartbeats in 6 seconds, that gives you a heart rate of 160 beats per minute. If you do not deserve these responses, gently tap or flick the soles of the feet or rub the back. Many newborns require some form of stimulation that will encourage them to breathe air and begin circulating blood throughout the lungs. These include positioning of the airway, drying, warming, suctioning, or tactile stimulation. Then you want to position the newborn on his or her back with the head down and the neck slightly extended. Then you want to place a towel or blanket on the shoulders to help maintain that position. If necessary, suction the mouth and then the nose with a bulb syringe or suction device with an 8 or 10 French catheter. All right, page 1203 under additional resuscitation efforts. You want to observe the newborn for spontaneous respiration, skin color, and movement of the extremities. You want to evaluate the heart rate by palpating the pulse at the base of the umbilical cord or brachial artery, or listen to the newborn's chest with a stethoscope. If chest compressions are required, use the hand encircling technique for a 2-person resuscitation. Perform BVM ventilation during a pause after every 3rd compression using a compression to ventilation ratio of 3 to 1. If you see meconium in the amniotic fluid or meconial staining and a newborn is not breathing adequately, consider quickly suctioning the newborn's mouth and nose after delivery and providing rescue ventilation. So go ahead and highlight that. That is on page, the last paragraph on page 1204. All right, so let's talk about the APGAR score. The APGAR score is the standard scoring system used to assess the status of the newborn. It assigns a number value, 0, 1, or 2, to 5 areas of activity. All right, starting with appearance. Newborns often have cyanosis of extremities for a few minutes after birth, but the hands and feet should pink up quickly. Go ahead and highlight that under appearances. Also, you want to, again, measure the pulse. Then grimace or irritability. Grimacing, crying, or withdrawing in response to stimuli is normal and indicates the newborn is doing well. Go ahead and highlight that also. Also look at activity or muscle tone and respirations. All right, at the bottom it said APGAR score should be calculated at 1 minute and again at 5 minutes after birth. Go ahead and highlight that. And that table 33.4 is a good table to remember because you're liable to see that on the National Registry. All right, start on page 1205 and then through 1206, you see steps for assessing newborn. You want to quickly calculate APGAR score to establish a baseline for newborn status. Stimulation should result in immediate increase in respirations. If not, you must begin ventilations with a BVM. If a newborn is breathing well, you should check the pulse rate by feeling the brachial pulse or pulsation in the base of the umbilical cord or auscultating a chest with a stethoscope. And that is number 3. Go ahead and highlight that on page 1206. And also, where it says the pulse rate should be at least 100 beats per minute, highlight that. And highlight also where it says, if not, begin ventilations with a BVM. All right, moving on down to number 4, where it says, if central cyanosis is present, administer a blow by oxygen by holding oxygen tubing at high flow close to newborn's face, and you will set the oxygen flow rate at 5 liters per minute. Go ahead and highlight that also. All right, situation where assisted ventilation is required, you should use a newborn BVM. Newborn does not, begin breathing on his or her own or does not have adequate heart rate. Continue CPR and rapid transport. All right, let's look at complicated delivery emergencies, page 1206, starting with breech delivery. The presentation is the position in which the infant is born or the body part that is delivered first. Most infants are born head first, called a vertex presentation. Occasionally, the buttocks are delivered first, which is called a breech presentation. The fetus is at great risk for trauma from delivery, and prolapse cords are more common in a breech delivery. Breech deliveries will usually take longer, so you will have time to transport the pregnant woman to the hospital. However, if the buttocks have already passed through the vagina, the delivery has begun. So you want to prepare for a breech delivery the same way as you would for normal childbirth. You want to allow the buttocks and legs to deliver spontaneously, supporting them with your hand to prevent rapid explosion. Let the legs dangle on either side of your arm while you support the trunk and chest as they deliver. The head is almost always face down and should be allowed to deliver spontaneously. Make a V with your gloved fingers and position them in the vagina to keep the walls of the vagina from compressing the fetus airway. All right, page 1207, presentation complications. On rare occasion, the presenting part of the fetus is neither the head nor the buttocks, but it could be a single arm, leg, or a foot. This is called a limb presentation. An infant with a limb presentation cannot be successfully delivered in the field, so you must transport that patient to the hospital immediately. All right, and you'll see that on page 1207. Go ahead and highlight that. If a limb is protruding, cover it with a sterile towel and never try to push it back in and never pull on it. All you can do is drive faster to the hospital. All right, and the prolapse of the umbilical cord is where the umbilical cord comes out of the vagina before the fetus and must be treated in the hospital on a surgeon's table. Do not attempt to push the cord back into the vagina. Your job is to keep the fetus head from compressing the cord. So what you want to do is you want to carefully insert your sterile gloved hand into the vagina and gently push the fetus's head away from the umbilical cord. And once you do that, you do not remove your hand. Your hand stays inside that pregnant woman. So you want to give high flow oxygen and transport rapidly. And with your hand inside the woman's abdomen, you want to stay that way until pretty much the mother's on a surgeon's table and the surgeon shakes your hand from inside of the woman's stomach. All right, moving on to spinal bifida. Spinal bifida is a developmental defect in which a portion of the spinal cord or meninges may protrude outside the vertebrae and possibly outside of the body. Cover the open area of the spinal cord with a sterile, moist dressing immediately after birth to help prevent potentially fatal infection. Maintenance of the newborn's body temperature is important when applying moist dressings because moisture can lower the newborn's body temperature. All right, under multiple gestations, page 1208, twins occur about once in every 30 births. Twins are usually smaller than single fetuses, and delivery is typical but not difficult. The procedure for delivering twins is the same as a single fetus. However, you will need some more supplies from an additional OB kit. Record the time of birth of each twin separately, and twins may be so small they look premature. All right. Under premature birth, where it says any newborn who delivers before 8 months or 36 weeks or weighs less than 5 pounds at birth is considered a premature baby. So go ahead and highlight that. And premature babies require special care to survive. All right, on page 1209, postpartum pregnancy refers to pregnancies lasting longer than 42 weeks. Postpartum fetuses can be larger than typical 40-week fetus, sometimes weighing up to 10 pounds or more. The larger size can lead to problems with the woman and fetus, a more difficult labor and delivery, increased chance of injury to the fetus, increased chance of C-section, and the woman's also at risk for prenatal tears and infection. Postterm newborns have increased risk of meconium aspiration, infection, and being stillborn. And moving on down to fetal demise, the onset of labor may be premature, but labor will otherwise progress normally in most cases. So do not attempt to resuscitate an obviously dead neonate. And 1209, deliver without sterile supplies, even without OB kit. You should always have eye protection, gloves, and protective mask with you. You want to deliver the fetus as if sterile supplies are available. If possible, use freshly laundered sheets and towels, and as soon as newborn is delivered, wipe the inside of the mouth with your finger and clear away blood or mucus, and do not cut or clamp the umbilical cord. As soon as the placenta delivers, wrap it in a clean towel or put it in a plastic bag and transport it to the hospital. Always keep the placenta and newborn at the same level, or evaluate the placenta slightly if possible, and keep the newborn warm. All right, postpartum complications. All right, right there where it says some bleeding always occurs with delivery, but bleeding that exceeds approximately 500 milliliters is considered excessive. Go ahead and highlight that. If bleeding continues after delivery of the placenta, you should massage the uterus and check your technique and hand position. You want to treat signs and symptoms of shock. Excessive bleeding after birth is considered by the muscles of the uterus not fully contracting. You want to cover vagina with a sterile pad, changing the pads as often as possible. And you want to administer oxygen if necessary, monitor vital signs frequently, and transport the patient immediately to the hospital. You never want to hold a woman's legs together in an effort to stop bleeding, and you never want to pack the vagina with gauze pads in an attempt to control bleeding. Postpartum patients are also at increase for embolism, most commonly a pulmonary embolism. A pulmonary embolism results from a clot that travels from the bloodstream and becomes lodged in the pulmonary circulation. This obstruction will block blood flow to the lungs and potentially life-threatening. If you deliver a newborn in the field and a woman begins to report sudden difficulty breathing or shortness of breath, consider pulmonary embolism as a possibility. Also suspect a pulmonary embolism in patients of childbearing age with respiratory complaints who have recently delivered, especially with sudden onset of difficulty breathing or altered mental status. And with that, I will see you next time, and everyone stay safe.